Welcome to H&HN Daily. I'm Suzanna.Jones.Kampschneider, Senior Editor for Hospitals and Health Networks magazine. 2 to 3% of hospitalized patients fall each year. That's 1 million patients in U.S. hospitals, with 30 to 50% resulting in injury. Fall risk reduction is a major patient safety initiative in healthcare. Today, I'm joined by Catherine Jones, Associate Professor at the University of Nebraska Medical Center in Omaha, and Carol Kampschneider, Vice President of Clinical and Regulatory Services at St. Francis Memorial Hospital in West Point, to discuss implementing a multi-team system to decrease fall risk. Welcome, Catherine and Carol.
Thank you.
Thank you.
Thank you for joining us today. What's a multi-team system approach, and how is this different from what others use to decrease fall risk?
So a multi-team system is really a team of teams. Most people are familiar now with what we think about as teamwork and teams, but healthcare is so complex that what we actually have is teams of teams working towards a collective goal. And what we've acknowledged is that fall risk is multifactorial. So what we have to have is team members with complementary skills, not the same skill set. The joke in our project is if you ask a nurse why a patient fell, you might get an answer because they didn't put their call light on. If you ask a pharmacist why a patient fell, they might say it's because of the Ambien. If you ask a physical therapist, they'll say because their center of mass was outside their base of support. So we really need teams of teams, a team to coordinate all of the operational environment, and then the core team at the bedside. And so the multi-team system is really acknowledging that healthcare environment is complex and we have to bring together different teams to address it.
Carol, how does this differ from other team approaches that you've used to decrease fall risk?
Well, we really hadn't been looking at our fall to anything to decrease our fall in our hospital, other than just nursing looking at the falls. But we didn't have any approach as to how do we decrease them, what do? We weren't benchmarking. And so we had no process, no structures in place to decrease our fall risk rates.
Did you do a gap analysis to help you improve your processes and get a handle on what was going on?
A gap analysis was done, and we looked at the things that we should have in place in order to have an effective falls reduction program. We needed to have a multidisciplinary team. We needed to have a specific definition for falls. Our fall definition wasn't inclusive of what the ARC had identified as a fall definition, so we needed to change what our fall definition was. We didn't include injurious falls of if they had a skin tear, because normally in the elderly, they can just hit their arm on the side rail of a bed and have a skin tear. So if they fell and had a skin tear, we didn't feel like that was an injury. Well, in the fall program, we needed to be including those in our injuries. We were looking at injuries as being something that we had to medically treat, a broken bone or a head injury. So that was something. And then we didn't do any fall risk assessment scoring when our patients were admitted to the floor.
So the gap analysis, Susanna, is a formal tool that's posted on our website. Just put capture falls in Google and it'll take you there. And it's evidence-based and it takes you through the structure of fall risk reduction, as Carol said. Do you have a team? Who's on the team? What type of tools do you have? And then it also looks at organizational processes and then unit level, universal and targeted interventions. So it's a pretty exhaustive tool and very evidence-based, and it's out there for everybody to download freely because our project is supported by the Agency for Healthcare Research and Quality.
What are some of the strategies and tools that teams can use to improve their effectiveness?
Well, first and foremost is really understanding how the team itself functions. And one of the measures of that is just team reflexivity. So do we actually look at how our team functions? Do we change the way we operate based on data? So team reflexivity is one tool. The gap analysis we talked about, but many of the tools that you can think about also focus on the training that's provided. As Carol said, do you train people on how to use the various tools? The PostFall Huddles, those are key interventions and strategies that were used.
Carol, how did you use the PostFall Huddle, and can you explain that to us?
Well, right away after a patient fell, we tried to get the nursing staff that was available on the floor together and to look at what are the interventions that we had in place. Did you have the bed alarm on? Did you have, if they were scoring high on the FRAS, 15 or more, did you have the mats alongside the bed? Or if they were in the chair, did you have the chair alarm on? And was the alarm that you shut off when the patient gets up, was that in their reach so that they could shut it off? Those are some of the things that we look at initially right after a fall. And then when the coordinating team gets together, when you have PT and OT and pharmacy and nursing staff and our QI coordinator and all of those people together, we try to do that within 24 hours after our fall. And we look at, was there anything else that we could have done to prevent the fall, and can we prevent that same patient from falling again?
Carol, what were the results of this project and putting this program in place in terms of your fall rates and your injurious fall rates?
Well, we started out, our fall rate was 7.31 per 1,000 patient days. And as we finished, our fall rate ended up at 1.41 per 1,000 patient day. And that was between 2 years. And right now we are at 175 days fall free. And we're very proud of that.
And I think it's important to note, Suzanna, that a very tangible outcome was the decrease in the fall rates. But as the theme of this conference is improving safety and quality and culture, and we've got measures of patient safety culture and how their culture became more positive in terms of organizational learning, in terms of teamwork both within and across hospital departments, and non-punitive response to error. You can see that this post-fall huddle mechanism is a way for immediate learning where people are really focusing on the processes and the system. And so they're able to learn without this sense of blame and shame. So a direct result of the project as well is improvements in perceptions of patient safety culture.
Thank you for joining us today.
You're welcome. It's our pleasure.
Yes.